it's in the breaking we come unbound. And it's in the giving we are found. Yeah, you could barely change.
Welcome to A Medicinal Mind, Wisdom and Well-Being, a podcast dedicated to the telling of authentic stories and the sharing of insightful wisdom, exploring science and spirituality, medicine and Mother Nature. No topic is off limits when it comes to growing our personal understanding and supporting our collective well-being. With your host, Dr. Rob Abbott, a family medicine resident practicing spiritually focused and evolutionarily informed functional medicine, we hope to nourish your being so that you can flourish in whatever the moment has called for you to do.
And I know you try.
Hey guys, this is your host, Rob Abbott, and today I wanted to actually mix things up a little bit. I've been interviewing some wonderful guests recently, and thought I'd share a few insights and some thoughts from some of my recent work, and perhaps, just have a different conversation. So, without getting too much into the details, I'll simply say that recently I was kind of upset by some new recommendations from the United States Preventative Services Task Force. I know it's a mouthful. The USPSTF. An organization that's sort of charged with the responsibility of pouring through all of the relevant research, data, studies about various preventative and screening interventions to identify those with the most efficacy, the least bit of risk, and to provide recommendations with different levels of relevance so that we can, as clinicians, be guided in what is going to be the best care for our patients. So some examples of the recommendations, they apply to behavioral counseling, screening for sexually transmitted infections, screening for lipid disorders, screening for breast cancer via mammography, or screening for blood glucose issues. There's a wide variety of guidelines, and would take me hours to go through every single one. But basically, we are provided these recommendations, and they provide a grade from A to I being incomplete, of what is the level of benefit or potential harm for a certain test. So for instance, if a recommendation is given an A-level recommendation, there is a moderate to high level of evidence that a given screening test or intervention will have a benefit for the individuals involved. So level A recommendations have both high level of evidence and a high likelihood of benefit with a low risk of harm. These are recommendations in general that should be followed almost to the T, as given from the USPSTF. Now, going down, a grade B recommendation is one where there's mild to moderate level evidence that there is potentially a benefit. So not the same degree of evidence as a grade A recommendation, but some decent evidence that a certain screening test or intervention is going to be of benefit to the individuals involved. Now, where we start to get interesting is when we get down to grade C. So grade C recommendations are basically kind of a hand wave, sort of saying there's neither supportive or non-supportive evidence for a given intervention. So there's unlikely to be benefit, but there's also unlikely to be harm. So we can't really give a recommendation on whether or not you should do this intervention or provide this screening test. So these grade C recommendations open up this interesting box of, well, what do we really do? We'll come back to this in a second, but keep that in the back of your mind. So moving down, we now have grade D recommendations. These are also pretty clear recommendations to those of grade A. In this case, grade D recommendations are actually saying that this screening test or this intervention is likely to be harmful and should be avoided in clinical practice. So in general, for most clinicians, we are paying attention to making sure we do and follow grade A recommendations and grade B recommendations, and in following grade D recommendations, making sure we do not perform that intervention as it's likely to be harmful. Example of one of these that was just updated was screening for thyroid cancer in asymptomatic individuals. There was moderate evidence that this was actually harmful, led to overdiagnosis, overtreatment, and other burdens on the individual. So grade D recommendations do not do. I think D as in do not do this test. And then lastly, we could kind of move to grade I. I just stands for incomplete. There's just insufficient evidence to provide any kind of recommendation, which is different than grade C, right? So grade C was sort of a hand waving. There is evidence, but it says there's not really a benefit, there's not really a harm. We can't really recommend this. Grade I is saying, well, we just can't even make a recommendation. There's just not enough evidence for us to say either way. So now that we've kind of gotten a little background of what are these recommendations, why are they in place, it can bring us to the topic at hand, or what I found to be rather relevant. So just a couple days ago, a recent recommendation was released from our good friends at the USPSTF, speaking to the efficacy for healthful diet and activity or exercise recommendations for those individuals who do not have obesity, hypertension, dyslipidemia, diabetes, or any heart disease, coronary artery disease. So this recommendation is basically targeting those individuals we are identifying as quote-unquote healthy. Now, we've only looked at, we're only looking at 5 quote-unquote diseases, disease states that we're saying are identifying patients as not healthy. So obesity, hypertension, dyslipidemia, diabetes, and heart issues. There are a wealth of other issues that can be going on, which I would say would qualify an individual as not being healthy. And to put it actually rather in a better perspective, the individual themselves, we as individuals can identify and say if we believe we're unhealthy. But for the sake of research, we are identifying, to set some boundaries, who is a healthy adult. So we're looking at a population we're saying is healthy adults. Now, what does the USPSTF say? Well, here are their words from their summary statement. The USPSTF recommends that primary care professionals individualize the decision to offer or refer adults without obesity who do not have hypertension, dyslipidemia, abnormal blood glucose levels, or diabetes to behavioral counseling to promote a healthful diet and physical activity. Existing evidence indicates a positive but small benefit of behavioral counseling for the prevention of cardiovascular disease in this population. Persons who are interested and ready to make behavioral changes may be most likely to benefit from behavioral counseling, a grade C recommendation. So let's take a pause here. What are they saying? Going back to our definitions of grade A, B, and C recommendations, they are essentially saying, we can't really recommend routine health education for those individuals we are deeming as healthy, as there is not a perceived benefit for decreasing their risk of developing cardiovascular disease. Now, when I first saw this, I'd have to admit, my blood just started boiling. I had to take a mindful moment away and say, are they really saying we should not be speaking to individuals about healthful diet and activity in order to promote well-being? So let's take a step back once again. taking a pause here before I get a little upset. Who exactly was excluded from this group? Let's think of percentages. So if we look at current data as we can get, 35% of Americans are considered obese. 10% have diabetes, around 30% have high blood pressure, and 30 to 31% have high LDL cholesterol levels. Now, I won't get into the fact that having a high LDL cholesterol isn't exactly a sign of true dyslipidemia, but for the sake of this conversation, we'll use it as a surrogate. So, sadly, it looks like there's a massive amount of people, not the majority, but a huge proportion of our population that actually do not qualify for this recommendation. Over, only 2/3 of the American population are actually relevant individuals for this recommendation. That in and of itself is a little scary, right? We have reached a point where, 1/3 of individuals are obese, 2/3 are overweight, 1 in 10 people have diabetes, 1 in 3 individuals have high blood pressure. This is not something to be complacent about. So, we're looking at healthy adults, and we're saying, what is beneficial to you? Now, we can look at so many different markers. To me, health, as I mentioned earlier, is defined by you. Maybe it's social connection. Maybe it's your ability to exercise. Maybe it's your ability to work and contribute to society. We can all define our quality of life, our well-being, in numerous ways. This recommendation specifically was applied to the prevention of cardiovascular disease. Now, here is my sort of first problem with this marker. So essentially, this study is already saying we are looking at individuals, I should say this recommendation, not this study, this recommendation is already looking at individuals who they say are at very low risk of developing cardiovascular disease based on the known and traditional risk factors. So if we're already saying these individuals are at low risk, then no matter the intervention that's applied, you're going to have to do something incredibly drastic in order to see a significant decrease in any of those individuals ever developing that disease, right? So let's just take a population of 100 people. We'll say of these 100 people, 100 healthy adults, maybe if they continue living their current lifestyle, only 3% or 3 of them go on to develop cardiovascular disease. That to me is you're fairly low risk, 3%. So in order to take that 3% down to, say, 1% or 0.5%, it's going to take something pretty remarkable to realize that effect. And even still, going from 3% to 2%, we can start to get into these relative risks and how much did you really reduce someone's risk. And from 3% to 2% is actually a pretty big percentage in terms of relative risk, but the absolute risk reduction is really not that much. And so that's kind of what this recommendation is saying. There is a small benefit, but it doesn't seem to be really significant. And I would say, well, that's almost duh. I think, like I said, what kind of intervention are we going to be talking about, or what size population are we going to need to study to see an effect of preventing a disease you've already said they're at low risk for developing? So we'll stop there and sort of say, once again, take a step back. Why are we even wanting to prevent a disease or study what's going to be helpful for preventing a disease state that we've previously identified you at being low risk for? It's, I kind of question what's the real relevance of this. So what if instead we looked at these interventions and said, well, what if we looked at other perceived benefits? Once again, what if the individual decided for themselves what was a benefit of such, behavioral health counseling? Coming back to this idea of patient-oriented outcomes. Certain things as overall mortality or overall morbidity, or the prevention of other disease states, or quality of life, or getting more granular, you said one's ability to spend time with family members. We can get as granular as you want. But why aren't we looking at other markers of benefit? Now, the studies in this that were used, over 120 of them that were pooled as part of this recommendation, were generally not powered enough to report on mortality. Instead, a subset of them, around 30, who were sort of medium to high intensity in terms of their overall intervention, were able to report on intermediate outcomes, right? So this idea of heart attacks and strokes, these sort of intermediate submarkers. And some of the examples of these intermediate outcomes, these intermediate markers that were found were sort of a 1 kilogram weight loss, or a 1.3 millimeters of mercury decrease in systolic blood pressure, or a 2.6 milligram per deciliter decrease in low-density lipoprotein cholesterol. Now, just looking at those numbers, sounds like they were statistically significant, but changing your cholesterol, your LDL, by 2.6 milligrams, if anyone's listened to Chris Masterjohn's talks, his podcast, you realize that is just within the standard range of normal. And is that really meaningful? Or a 1.3 millimeter mercury decrease in systolic blood pressure, or 1 kilogram weight loss, all of these things are within sort of measurement error. So statistical significance, but almost no clinically relevant significance. So you see, we're looking at these intermediate markers, and if that's all we're looking at, then I would kind of agree with the USPSTF. These seem, extremely small and practically irrelevant. If I was going to counsel someone for 15 to 20 minutes, and that's what I would expect from some of these surrogate markers, then you know what? Probably wouldn't spend the time doing it. So, bringing this back again, well, what's the problem, right? We're looking at the wrong markers. Can we choose and allow patients to decide what is it that they want to improve? I won't go into that laundry list again of the many things that we can decide on, but it seems silly to be looking at these intermediate surrogate markers that are not patient-oriented and, as we mentioned before, are unlikely to change in a population we've previously identified as not really having these issues, not having issues with cholesterol, not having issues with weight, not having issues with blood pressure. So how are we going to see a change if we've said they don't really have an issue in the first place? So bringing this back, once again, trying to keep us in this perspective, I then start asking some questions. Okay, so it seems like these effects for these intermediate outcomes were not that significant. What if we had changed the measures, looked at other benefits? Would we have seen an effect? Or perhaps let's start to question, okay, well, is there, who was involved in this counseling? Was it actually primary care physicians, or was it behavioral health coaches? Who was involved in the teaching? And if we look at the recommendation, we can see that there were actually a variety of individuals involved in providing counseling. So I'll read the statement from the recommendation. So the main behavioral change techniques were diverse, invariably included goal setting and planning, monitoring and feedback, motivational interviewing, addressing barriers to change, increasing social support, and general education or advice. These counseling interventions were variously delivered by primary care clinicians, okay, we got primary care docs, health educators, behavioral health specialists, nutritionists, dietitians, exercise specialists, or lay coaches. Wow. Okay. So, and I guess to even wrap that up more, we could say what types of interventions were involved. We saw the techniques. What types of interventions? They mentioned face-to-face individual and some group counseling over telephone, email, text, or in-person visits. So pulling this all together, I think on the surface we see there's a huge variety of services and counseling being provided here. There are, we're talking about motivational interviewing, we're talking about in person, we're talking about over the phone, all of these different techniques. And then in the end, we see there's 6 or 7 different types of professionals providing this counseling. So, it brings in this idea of, well, who are we speaking to with this recommendation? If we go back to the statement, I think we'll remember it specifically looked at and was speaking to primary care professionals. But if we look at what was studied and who was delivering the interventions, I can't give you a direct percentage, but if we say that each of the individuals that they listed were equally involved, then primary care people were 1/6 or 1/7 of those delivering this health education. So how can we make a recommendation speaking to primary care clinicians when they were really estimating here only 1/7 of the people involved providing the education? It seems a little backwards, doesn't it? And like I said, confounding things together, these studies are so heterogeneous, we can't really say what was or isn't effective. We are saying collectively, when pulled together from low intensity to high intensity with all of these different people, there doesn't seem to be much of an effect when measured for prevention of cardiovascular disease. So I see this as, okay, we seem to be picking up on a trend that there's this huge variety of things. We're kind of shotgunning approach when it comes to behavioral counseling. Primary care people may be involved some 15% of the time, but we're going to make a recommendation to all of you that this is perhaps something you need to decide on your own is relevant or individualize, but actually shouldn't be routine for all patients. So, I'm wondering, I've pointed out some things here of maybe reasons why we're not seeing an effect with these interventions. And one of them was like, well, maybe we're not looking at the right outcomes. Maybe we're not asking patients, what are the relevant things that you would like to improve upon? Another is, well, perhaps we're not seeing an effect because the education that was delivered wasn't relevant, helpful, or really actionable. Or, bringing it to sort of another big picture framework, was the content actually wrong? Or was the delivery of the content impractical and irrelevant? I think we could all bring up many examples in our education where we were presented with information that was correct, was very truthful, but was delivered in a manner that was inaccessible, irrelevant, or fractionated. And so therefore, it was very difficult to learn it, to make it a part of our knowledge base. On the other hand, there's also probably been many times where there has been information and you've wanted to really understand it, to grasp it, but it was actually just delivered very poorly, but was just straight wrong. If we're providing education that's not helpful or is not based in truth, then I would not expect to see a benefit from that intervention. It's like, here's a silly example, right? Is if I wanted to get better at jump rope and you taught me how to sprint on the track, I don't exactly see how that's going to be making me better at jump rope. Now, it seems like, well, okay, you're doing physical activity. It could be some really amazing coach. But if we're telling people information that's not relevant or not actually going to be helpful, then we really can't expect to see a beneficial effect from those studies. So I think, Peter Attia, this amazing doctor, has spoken quite a bit about the sort of relative obesity epidemic, and diabetes. And he brought up a very good point about we see diabetes as a failure of the individual, right? But he brought up this point of, are we actually, as clinicians and healthcare educators, are we actually failing our patients by not providing the right type of advice for them to succeed? He describes there's plenty of people who would love to lose weight. I don't know anybody who wants to be overweight, who wants to have high blood pressure, who wants to be obese. Many people would like to be healthy and to achieve their perceived optimal well-being. So when presented with information and counseling that perhaps isn't really in alignment with what's going to help them, that's why they don't succeed. Not because a lack of motivation, a lack of compliance, or a lack of just ability to execute and make these lifestyle habits. And so we have to look and examine and say, was there a problem with the interventions themselves, either in their delivery or in the content that was being delivered? Now, I think you probably know from the space that I hold that I'm very much a sort of Paleolithic-based, evolutionary-based clinician. And so I recommend sort of the Paleolithic-style diet for the majority of individuals, a movement pattern that maybe replicates our ancestors, a variety of movements. And generally speaking, those are the types of foods and lifestyle that I tell my patients. Now, many of you probably have seen that the AHA or the ADA and various dietetic associations, their recommendations, or look at the My Food Plate recommendations, are not recommending a Paleolithic-based diet. So, is the reason we're not seeing an effect with these interventions because we're not telling people the right thing? We're not telling them actually what's going to make them better, what's actually going to make them live an optimal life. It's just a thought, just a question, but we need to start, digging deeper to see, right, why are we not seeing an effect? Is it the delivery? Is it the content? Is it because it's going to be impossible to see an effect based on the outcomes we're looking at? There's so many things at play here that we have to look deeper and recognize what's behind this recommendation. So, I've kind of been a little maybe negative in my view up to this point, but I want to end this with sort of a positive light. Well, at least slightly positive. The first is, this to me opens up a gateway to say, okay, maybe if we take these things as they stand, we can say, okay, maybe they're not working. So what can we do instead? Would group education with community social support and the education, and the education is founded on ancestral principles, on Paleolithic-based nutrition, on sleep hygiene, on stress reduction, on social connection? Because if we actually go back to the recommendation, they only looked at diet and activity. Would there have been effect if we looked at interventions that focused on sleep, social connection, and stress reduction? Maybe that's actually where we should spend our next 15 years studying. Let's not spend time based off of the recommendations encouraging diet or activity. And instead, maybe let's do group counseling focused on sleep. Maybe that's where the biggest effect's going to come from. I'm just postulating here, but like I said, putting a positive spin on this recommendation, maybe let's try something different. Let's try something different. Rather than simply not do it, let's try something different. So I sit here now and I recognize that, there's something else embedded in here that needs to come to the table. So with grade C recommendations. Now, remember, we talked about grade A, grade B, grade C. And grade C is being those that we can't really recommend for or against because it doesn't seem that there's benefit, but there's also not a harm. So the problem here is that in practical terms, because the USPSTF did not find grade B evidence of benefit. The provision of diet and activity counseling is not going to be routinely covered by private insurance. So, insurance is not going to cover time spent by a primary care clinician speaking to an individual, in this case a healthy individual, about diet or about exercise and activity. So we have now de-incentivized the primary care clinician speaking about these topics because guess what? If you're working in a traditional insurance model, you are not going to be compensated. You are not going to be paid. What would you be paid for instead? Let's see. What are some perhaps grade B recommendations? So ones that have a moderate effect and that insurance companies will pay for. So some examples of grade B recommendations include the discussion and administration of preventative medications in women at higher risk for breast cancer. So basically what this is saying is a grade B recommendation that, and we will compensate you for your time to discuss certain medications that can be taken to help prevent breast cancer. Or here's another one, grade B recommendation. Mammography screening for the identification and prevention of mortality from breast cancer for women aged 50 to 74 every 1 to 2 years. So I don't want to seem like I don't care about breast cancer. I do. But putting back our hats of what's truly preventative versus what's actually screening, we can see that they're advocating and saying it is worth our time and we will be compensated for discussing the use of medications to prevent a disease or the use of screening tests to prevent a disease state. But, in speaking about diet and lifestyle, we will not compensate you for speaking and counseling on these areas, which we know and have been shown in numerous studies to be well correlated with the development of cancer. This, to me, in the hierarchy of objectives, seems a little backwards. They're basically saying, I should talk about medications and tests that have a high false positive rate and are actually potentially detecting cancer, not preventing it, but detecting it. I should spend my time doing those things before doing counseling for things that may actually truly prevent the development of cancer altogether. That does seem a little backwards, doesn't it? So, bringing this back once more to why are we having this discussion? So, I see now that if this is the recommendation coming from a United States organization, this is way above institution level. We're not talking about just one institution. This is so broad-reaching, it's even hard to comprehend how many individuals are involved. But if we see their recommendation is going to affect so many people and influence behavior in clinicians. And I would argue, if there is a grade C recommendation, insurance companies, they shouldn't pay for it. Very rightfully so. We would be, kind of already are, bankrupting ourselves from high costs of healthcare. And if insurance companies were obligated to cover for grade C recommended screening and interventions, we would most certainly be bankrupt. So I do not blame them for not covering this. I do not blame them. But was there really a good reason to give it a grade C recommendation? Are we de-incentivizing, as I mentioned before, speaking about diet and nutrition? I think in the grand scheme of things, we are taking steps backwards. So I say here, given this recommendation, given what I know about how I would be compensated, this is sort of telling me I don't think I can practice in a traditional model. Now, I'll say I'm not planning to practice in a traditional model. After I complete my residency, I have no intention of being in a traditional insurance model because, as I see now, there is a service I would like to provide nearly all of my patients that I would not be compensated for. I couldn't make a living based off of what I understand from this recommendation. So I bring this to a close. I know it's probably been a little tangential, a little confusing, and even a little perhaps irrelevant, but I did, or should I say, I simply want to share my passion for preventing illness and disease and for promoting your flourishing. And in order to do that, I think I will execute my professional judgment to individualize the experiences and treatments of my patients. That, USPSTF, I will do. I will take that liberty. I will personalize the experience because I recognize its importance for everyone, healthy or unhealthy, sick or not sick. It is a priority to me. I hope you've enjoyed this short discussion, and please leave some comments. If you like this type of podcast, please let me know, and I can certainly share some more of my thoughts as it pertains to other medical issues and medical subjects. To perhaps leave on a more humorous note, I can't help but revisit the final sentence of the recommendation. Let me read it again. Persons who are interested and ready to make behavioral changes may be most likely to benefit from behavioral counseling. Now, I don't know about you, but perhaps that's the biggest duh moment of the century. That being said, motivation is not a prerequisite for making change. Feelings do not dictate our actions. Rather, actions will dictate our feelings. And perhaps with the right education, the right spirit, and a true heart, you can take somebody from a state of non-motivation to one of empowerment, willingness, and desire to change. I hope all of you feel empowered, loved, and supported in all that you do, for we are here in this together as a community seeking to serve others and to share our love with all that we meet. I hope you have a wonderful day. Thank you.
Thank you for your presence and willingness to receive a new narrative, a passionate perspective, and perhaps a deeper sense of connection with our collective purpose. Please share this podcast with any and all that you believe will benefit from its intention to relieve one's doing and engage one's being. Please share your comments about the conversation on our podcast page and leave a review in iTunes so that the voices in this space can spread to all ears ready to receive it. Music credit goes to Dillingham for their song Vessel. Remain open, stay curious, and forever be love.
You walked on fire, and I know you tried.